Good evening, everyone, and welcome to this webinar brought to you by Orthoclinical Diagnostics in collaboration with Thermo Fisher Scientific. My name is Shayma Munif, and I am the Regional Marketing Manager at Orthoclinical Diagnostics. And today's webinar is about saving lives and resources in the era of pandemic and beyond, and how BRAM's PCT can help you in patients management, risk assessment, and antibiotic stewardship every day. During this webinar, Dr. Jonas Fazakas from Semmelweis University in Budapest will share with us his experience on using PCT in identifying bacterial co-infection in COVID-19 patients and antibiotic treatment, and he will share with us some clinical cases. This will take us around 45 minutes of your time, and after that we will have the door open for questions and answers, and you can post your questions in the chat box on your right-hand side of the screen. And with that, please welcome with me Dr. Jonas, and please join us, Dr. Jonas. The floor is yours.
Okay, good evening, ladies and gentlemen. I am János Fazakas from Semmelweis University, and I work in the Department of Transplantation, but actually since 6 months, I work in COVID ICU and COVID medical departments. And my topic today is to share some information, practical infos about the procalcitonin, which had a clinical utility in COVID-19 patients and also in general patients. I start with two questions. The first one is about a patient, COVID-19 patient with severe hypoxic respiratory failure. Please give your opinion. Would you start antibiotics within 1 hour of admission if the PCT level measured at admission is below 0.1 nanogram per ml? Definitely, I cannot decide. This could be answers or no, but I remeasure the PCT on the second day. Please give your opinion about this question, according to this question.
Dr. Jonas, apologies for interrupting, but your camera is off. If you enable your camera, please.
Oh, I'm sorry.
Thank you so much. Yes, perfect.
Okay. Could you see my screen?
Yes.
Okay. So, the second question . The second question is about a COVID-19 patient, also with severe hypoxic respiratory failure. The question is about that, about the prognosis, the patient prognosis. What would be the patient prognosis if the PCT measured at admission is above 1 nanogram per ml? It's a good prognosis. I cannot decide. Or it means that we will have a bad outcome, so we have a poor prognosis, and I remeasure the PCT on the second day. Please give your opinion. These questions are quite important because they are from the practical field. Because when we admit a patient with COVID-19 with severe hypoxic respiratory failure, we should known that they have only pure viral COVID infection or they have a mixed infection with the bacterial infection in plus. And according to the prognosis, we should know that the patient should be transferred in an ICU department or should remain in an also could remain in a COVID medical department or so it's about prognosis. Okay, so this is my agenda. So we have some conundrums in COVID-19. First, I will share some information about the general aspects of PCT. Then I show you some cases, a PCT clinical case. Then I will have some slides about the PCT utility in COVID patients, also PCT clinical cases, COVID-related, and PCT clinical cases according to the antibiotics stewardship. What do we know about the PCT? We know that the PCT is produced mainly by the immune cells. At the onset of the infection, immune cells start to produce PCT, but also PCT could be produced by the parenchymal cells. Every organ is able to produce PCT, but in a small amount. When we measure a PCT level in our patient with multi-organ failure, 80–90% of the PCT measured is produced by the immune cells, mainly by the monocytes, and 10–20% according to the multi-organ dysfunction is produced by the parenchymal cells, compared to the CRP, which is produced only by the liver. The monocytes play a major role in the PCT production because they are able to amplify the PCT production, because at the local site of the infection, when the monocytes arrive, they produce PCT, and the PCT, according to the bacterial infection, act as a chemokine and that attract at the local site of the infection more and more monocytes, which produce more and more PCT. You can see the dyed monocytes with green, which are producing PCT at the local site of the infection. And they modulate also the vasoregulation, and they have an immunomodulation. And if they arrive in the blood, and from the local site we will have a systemic infection, then the PCT start to increase in the blood, and we are able to measure higher level of PCT. And according to the PCT level, we have also organ dysfunction and prognosis. Very important feature of the PCT is the half-time of the PCT. PCT start to be produced at the onset of the infection after 4–6 hours. It has a maximum production of 50 nanogram per ml per hour, and it will peak at 16 hours after the onset of the infection. In case of appropriate treatment, the PCT production stop, and also only the clearance will influence the PCT levels, and the PCT lifetime is around 22 hours, 23 hours. I always count with 24 hours. It's more or less more practical. For me, if I have an appropriate treatment on the bacterial infection with antibiotics and source control, then the PCT must be halved more or less every day. So please notice this half time of the PCT. PCT kinetics, not only the absolute value, but the kinetics help us to assist an antibiotic treatment. In medical patients, because of the pathological molecular patterns, PCT is induced, and we can diagnose the infection. Increasing kinetics help us to diagnose the infection. The PCT will peak. We should memorize this peak level, because if we have an appropriate treatment, the PCT will be halved every day. And when the PCT will drop with more than 80% of the peak level, we should be ready to stop antibiotic treatment. If we have an inappropriate treatment of the infection, then the PCT production, reinduction of the PCT occurs, and the PCT levels remain in the highest range. In surgical trauma patients, it's a little bit different, because damage-associated molecular patterns, according to extent and site the surgery, can induce small production of PCT, but compared to a bacterial infection where we have reinduction of the PCT, in surgical patients we have only a monoinduction of the PCT. So after the surgery, we are able to measure a higher PCT, 1, 2, 3, 4, 5 nanograms according to the site and the extent of the surgery. But after that, the PCT clearance will occur and the PCT will be halved every day. However, in the postoperative course, when we observe a re-increase of the PCT in a highest range, this means a secondary bacterial infection, a nosocomial infection. This is the point when we should send cultures, and according to the cultures or empirically, we should start an antibiotic treatment. And if our treatment is appropriate, the PCT clearance will occur and the level will decrease, and we will be able to stop the antibiotic treatment or to be ready to stop the antibiotic treatment when the PCT will drop with more than 80% of the peak value in this case, or the absolute value is below 1 nanogram per mil. So this is what this is the how to say the management, how we use the PCT kinetics to assist the antibiotic treatment, to start, to follow up, and to be ready to stop in an earlier phase. We have data about these kinetics. Also in low respiratory tract infection, this is the well-known Budama study, the ProRata study. They start and stop the antibiotic treatment according to the PCT value in low respiratory tract infection. And if the PCT was below 0.25 nanogram per mil, the concentration, the antibiotics, the use of antibiotics was strongly discouraged. However, so you should withhold the antibiotics in these cases. However, if the PCT level at the beginning were above 0.5 nanogram per mil, then the use of antibiotics was strongly encouraged. And according to the stop of the antibiotic treatment, as I said, more than 80% of the drop in the peak value, or less than 0.5 nanogram per mil, was the moment when the stopping of the antibiotics was encouraged. However, if they didn't observe clearance of the PCT and the level of the PCT was above 0.5 nanogram per mil, the changing of the antibiotics was strongly encouraged because it was the signal of inappropriate treatment. We reinforce these data from the ProRata study with my friend Zsolt Molnár. For our point of view, we don't treat numbers, we don't treat PCT levels, we treat the patient. So we need the clinical improvement parallel with the micro results. So we have a clinical trigger, a microbiological trigger, and an inflammatory trigger, which is the PCT. And if all three of them they are positive, then we should be ready to stop an antibiotic treatment. However, if it is not, then we should change antibiotics, we should reassess the organ support, we should exclude other sources to send culture, and so on. I show you a clinical case. It's a patient with urinary tract infection and pneumonia. It was a kidney transplanted patient on hydrocortisone because of the sepsis. It was mechanically ventilated in condition of shock, arrived in the ICU. Piptazo and amikacin was given because of the urinary tract infection. The PCT was 16, but you can see that continuously is increasing, and the chest X-ray showed us an atypical pneumonia, so doxycycline was added, and after that, the clearance of the PCT occurred. The PCT is hard every day, and we stopped antibiotic treatment at the level of 3 nanogram per mil, but at this level, after 6 days, the patient was extubated. It was without vasopressors, with good urine output, so it was a clear clinical improvement, and also all antibiotics were appropriate, inclusive according to the cultures, and we discharged from the ICU with a level of 1 nanogram per mil. And later on, they remeasured the PCT because to check the rejection infection question in the transplant department. This is why we have these values continuously in the next week. The PCT guided antibiotic stewardship was declared also by an international expert consensus. And in primary care, emergency department, medical departments, the clinical diagnosis, the clinical evolution, the micro and the PCT kinetics play a major role. If there is uncertain bacterial infection onset, so the infection, the etiology of the infection or the condition has a low probability for bacterial infection, they do not recommend antibiotic treatment. But if, based on your clinical judgment, if you consider that you should start antibiotic treatment, you could start it, but you should repeat the PCT measurement. And if the PCT didn't increase next day or next after 24 hours and remain below 0.25 nanogram per mil, you should stop the antibiotic treatment. If the PCT is above 0.25 and the probability of bacterial infection is high, then of course you use antibiotics based on clinical judgment because they are empirical, but you should remeasure the PCT every day or every second day to detect the peak level and to detect the drop of the PCT till the 80% of the peak level, when or the absolute value below 0.25 nanogram per mil, when you should stop the antibiotic treatment. This was the opinion of the international expert consensus. I will show you a small movie. This is a Petri dish, but it's a mega plate. It's not a small Petri dish as in the lab. It's a mega plate, a big mega plate. And they did a movie according to the bacterial growing on these mega plate. But in this part, 1,000 fold of MIC of antibiotic was included in the mega plate in the Petri dish, and they put E. coli at the sides. You can see how the E. coli is growing, and then they did this movie in more than 2 weeks, and you can see that after 4 days we have resistant strains, 1 MIC, then later on you can see here 10-fold MIC of Cipro. E. coli is resistant. We have multi-drug resistant bacteria here, then pan-resistant drug bacteria here, and later on even 1,000-fold of MIC antibiotic concentration was unable to stop the growing of the bug. So this will happen in your patient if you don't stop antibiotic early. So every day in plus, compared to the inflammatory response, compared to the clinical improvement, compared to the other settings which were said by me, help the patient to get MDR bacteria and the nosocomial infection. Okay, now let's talk about the PCT utility in COVID-19 patients. Well, at the beginning, last year, mainly in China, but also in Europe, more of the patients received antibiotic treatment in pure COVID viral infection, because it's not so easy to distinguish bacterial infections from COVID-19 pneumonia. And these patients deteriorate very quickly, and we are under the stress, and we should do daily decision. And more severe the infection were, more often they prescribe antibiotics. You can see 800 patients, 72% receive antibiotic treatment. However, only 8% had bacterial co-infection. And so on. In these 1,000 patients, 70, 100%, 90% of the patients received antibiotic treatment unnecessary because the proved bacterial co-infection was only between 8 and 15%. Of course, we have a radiological background, and we know that we have 2-3 viral invasion during COVID-19 infection, and we have different phases of this COVID-19 disease with hyperinflammation, and it's difficult to distinguish the bacterial infection from hyperinflammation, pure viral hyperinflammation. So these are the conundrums when antibiotics should be initiated, which antibiotic should be empirically prescribed, what is appropriate duration of the antibiotic therapy in these COVID patients and COVID-19 patients, and which are the appropriate pathogens. Usually these are multi-drug resistant pathogens with ventilatory associated pneumonia, bloodstream infection, or urinary tract infection. Well, PCT helps us to do the decision more easily, because in COVID-19 infection, in the immune response, in the cytokine milieu of the viral infection, we have a lot of interferon gamma. And interferon gamma block the PCT production. This is why in pure COVID viral pneumonia or lower respiratory tract infection, the PCT remain below 0.1 nanogram per ml. However, the CRP, the TNF-alpha, interleukin-6, different cytokines will increase, but the PCT remain below 0.2 nanogram per ml always. When the patient had a viral infection, SARS-CoV-2, so it's a COVID-19 infection disease, and the patient had also a bacterial infection, so it's a mixed infection, then we have interferon gamma in the cytokine milieu, but we have the PAMPs derived from the bacterial infection site, and because of that we'll have PCT production, and the PCT will increase before the CRP according to the reinduction by the bug. And also this happens in secondary infection, nosocomial infection in COVID-19 patients. We have data about this, that in viral pneumonia, the PCT concentration remain below 0.1, 0.2 nanogram per ml with lowest CRP level in some cases, and bacterial infection in the background are in probability, they have high probability if the PCT is above 0.25, 0.5 nanogram per ml, and we have a higher PCT level as well. In this study, Cucumeli published the data in severe flu pneumonia, and they check also the bacterial co-infection, and the PCT helped them to discriminate the viral pneumonia from the mixed pneumonia in the flu season. And what they found, that if the PCT was above 0.5 nanogram per ml, then the odds ratio for a mixed pneumonia was around 13. The background was in their study more streptococci and staphylococci bacterial co-infection. However, in viral, only pure viral flu pneumonia, the PCT remained in the lowest range below 0.2 nanogram per ml. Of course, COVID-19 is not a flu, but also in COVID-19, disease, the PCT level will remain below 0.2 nanogram per ml. We have an iceberg of the COVID-19 pandemic. We have patients who had a mild, very mild disease. They could remain at home. Then we have mild, moderate cases which arrive in medical COVID departments and they need some treatment. And only 20% of the patients are severe cases, and the death rate is around 6%, but currently is increasing worldwide. So we have prognosis, we have severity in COVID-19 disease. The PCT had also this iceberg feature in the COVID-19 pandemic, because in the early infection phase, which is the viral replication phase, if we don't have a mixed infection, the PCT remains below 0.1 nanogram per ml. However, later on in the pulmonary and hyperinflammatory phase, when we could have also secondary bacterial infection, the PCT can increase, and it is prognostic for pneumonia, severe pneumonia, and even IRDS like feature according to the levels. But usually what we observe that rarely the PCT is about 10 nanogram per ml in mixed infection in COVID-19 disease. Usually is between 1 and 10 nanogram per ml found when we have a bacterial infection parallel with the viral infection. The IFCC information guide, which this is the latest publication this year in February, give us the main laboratory abnormalities which are observed in the unfavorable COVID-19 progression. And if you check the different labs or assays which are recommended by them, you can see we have liver function tests, some renal function tests, the blood gases, the blood count, but we have also the troponin, the D-dimer, and we have the procalcitonin. Very, very important. And you can see bacterial infection. This is the potential clinical significance, which this is the cause, the aim why they include in this guideline. Because if we misused antibiotics during this pandemic, after the pandemic, we will not have, we will have a lot of MDR bacteria and less efficient antibiotics later on. Also in the Surviving Sepsis campaign, they published guideline according to the management of the critical ill adults with coronavirus disease. And this was refreshed this year as well. And also they suggest to use empirical antimicrobials, antibacterial agents with weak recommendation, but they remark that you should de-escalate daily and re-evaluate the duration of the therapy. And this is the point where the PCT help you. It's quite important to avoid the MDR, PDR, XDR box, which in number are increasing during the pandemic. This is the Hungarian guideline I show you. We have the guideline based on different phenotype, but indifferent from the clinical picture, we have the lab, and you can see here where my arrow is, the PCT, indifferent the phenotype, the measurement of the PCT is mandatory in Hungary. So we should measure the PCT on daily basis. We should send also cultures, hemocultures, urine cultures, and the sputum, and we should check also the flu in these patients. Well, based on the Hungarian, the national, international guidelines, the PCT is recommended to be measured every day or every second day. And we know that we have minimum 3 viral loads and viral hits during the COVID-19 disease. So there is a there are waves, COVID-19 waves with hyperinflammation, fever, and the patient is improving, then deteriorating, improving, deteriorating, and to be sure that there is not a secondary bacterial infection in the background, you should measure the PCT parallel with the CRP. What are the clinical characteristics of coronavirus disease according to the antibiotics and the PCT? The first data were arrived last year from Wuhan, and if you check this paper, more than 1,000 patients were enrolled with non-severe, severe COVID-19 disease. 50% of the patients received antibiotics in spite of the PCT level. Only 5%, 4%, 14% in very severe cases that they had PCT above 0.5 nanogram per ml. So I guess that because of the deteriorating of the patient, they were under the stress, and they gave antibiotics unnecessary to these Chinese COVID-19 disease patients. And unnecessary, not in every case, because in 8%, 14%, they had mixed infection. What is the rate of the mixed infection in COVID disease? Well, if they checked retrospectively their data, they observed that in severe cases or critical cases, the patients were co-infected with other respiratory pathogens, and the rate was 1 to 4. And this is more or less what we can observe also in Europe, with Streptococci, Klebsiella, Haemophilus, E. coli, Staphylococci, Pseudomonas, Acinetobacter. So the co-infection rate is 1 to 4. So basically, one patient from 5 patients, 20% could have co-infection. And we should diagnose these patients at the admission that they had co-infection, because these are the patients who need antibiotic treatment from the beginning. The age of this patient was found in their retrospective study between 16 and 60 years. So these patients were younger or mildly old, but not the oldest generation as 80, 90 years old. So 1 to 4 the rate, 16 to 60 years the age. And the onset of this co-infection was in the first week, quite important, in the first week. So between, usually after 3 days. And gram-negative and gram-positive bacteria was in the background. But not only bacterial co-infection could be in the etiology of the deterioration, they could be also viral infections as well. Influenza, RSV, metapneumovirus, rhinovirus, adenovirus. But the co-infection rate with another virus is 1 to 10. This is why in the Hungarian guideline, the flu is included to test also the flu. Spanish data, Spanish intensive care data, they checked the 15-day survival in Vitoria in SARS-CoV-2 infection. And if they measured the PCT, but if they use the PCT cutoff value of 0.5 nanogram per ml, no difference was found in the outcome. However, if they use different cutoff values, 0.25 and 1 nanogram per ml, then you can observe the bars. The green bar is the survival, the red bar is the non-survival. And if the PCT was below 0.25, the survival was higher. If the PCT was above 1 nanogram per mil, which has a bad prognosis, the survival was higher. However, between them, the non-survivor was higher. Why was this difference in the outcome? Because these patients were given antibiotics unnecessary. 80% of these patients received antibiotics with a PCT below 1 nanogram per mil. And antibiotics harms organ damage, mitochondrial dysfunction, microbiome dysfunction, fungal infection, Clostridium difficile infection can occur, which increase the mortality. This is what they found in this study. Microbiota composition is quite important. You will see later on, because this is in the background of the increasing bloodstream infection in COVID-19 disease. And this microbiota composition reflects also the disease severity, because it shows us the dysfunctional immune response in these patients. We have a microbial immigration in the lower respiratory tract, with microbial elimination and reproduction. However, also in the gut, we have difference in the microbial microbiota, because the proteobacteria are increasing, the firmicutes are decreasing, the bacteroides are increasing, and according to the antibiotic treatment, this microbiota is changed significantly. You can see on the right side of the slide, if the patient received antibiotic or was without antibiotic, the microbiota was significantly different. Why it's so important? Because in the gut bacteria with severe bifidobacterial species, they were depleted, and because of that, they could have a microbiota dysbiosis and more bloodstream infection with translocation. Fever on the second week, who works in the practice in a medical COVID department or ICU department knows that it's very common to have fever on the second week in these patients. And the question is that in the background there is a bacterial infection or not. We should rule in or rule out the bacterial infection. However, we could have bacterial infection, ventilatory associated pneumonia, bloodstream infection, or urinary tract infection. We could have also fungal infection with a slight PCT increase sometimes, and we could have thrombosis, MVT, or pulmonary embolism. We could have hyperinflammation in the background with high fever, hyperpyroxia, and fibrosis as well. All of them cause fever. So PCT helps us to rule in or rule out the secondary bacterial nosocomial infection in these patients. So help us to diagnose and follow up pure COVID-19 pneumonia, to diagnose and follow up the mixed infection and the appropriateness of the antibiotic treatment, and to diagnose the secondary bacterial infection after the first week in the second week. Because in this case, the PCT always rise. And it's difficult to distinguish hyperinflammatory phase from non-bacterial etiology from the bacterial etiology without the PCT, only based on the CRP. So PCT is very helpful to do the differential diagnosis. Why we have so many nosocomial infection in COVID-19 disease? Because we were forced to use non-conventional temporary ICUs or departments, such as operating theaters, post-anesthesia care units. And the infection control measures were more directed to avoid the spread of the viral pathogens, and less attention was paid to the ordinary infection control practices, which was very hard, very difficult to use it in non-conventional temporary ICUs. And sometimes we misinterpreted PCT, and we misused the antibiotics mainly last year at the eruption of the COVID pandemic. This is why a lot of MDR, PDR, XDR, Enterobacteria, Acinetobacter, Pseudomonas, Klebsiella have been selected worldwide. And one of the reasons is the use or the misuse of the ceftriaxone. Why ceftriaxone? Because if you give only one dose, you have an antibiotic protection for 24 hours. You cannot run in and out to the patient. You should use the PPA. So it's better to use an antibiotic which is given only once a day. So this was the early antimicrobial treatment at the beginning in different centers, and we have these selection of MDR, XDR bacteria, which after the pandemic will give us a lot of troubles. I show you this study from an Italian ICU who were forced to expand the ICUs from 8 general beds to 30 coronavirus disease beds. And you can see the curvatura of the aisle, the different beds. And what they observed that compared to 2018, 2019, in 2020, they had a significant increase in the bloodstream infection, enterococcal bloodstream infection. This is what we are talking about. So PCT is very helpful to distinguish this. Incidence of the ventilatory associated lower respiratory tract infection, you should pay attention at the 7th day after 1 week, because the occurrence of the VAP, ventilatory associated pneumonia, is twice higher compared to the flu or non-viral infection. And these start to increase after the first week. So we should send cultures after every 2-3 days, and we should measure the PCT and the CRP daily to detect early the ventilatory associated respiratory tract infection and to have results from the culture to give an appropriate treatment. The bloodstream infection is very, very high in this COVID-19 disease. It's around 40%. It could be a pure one, primary bloodstream infection, which is a translocation from the bowels and from the gut. And there are some catheter-related bloodstream infection because of less infection control. But in some the bloodstream infection occurrence is 40%, and usually after the 4th day, after 1 week, we could have this infection as parallel with the ventilatory associated pneumonia as well. Why we have so many bloodstream infection? Because we have an epithelial blood barrier in the lung at the intestines. However, the extension in square meters of this barrier in the lungs, it's between 50 and 100. However, at the intestines, it could be between 250 and 400. So 4 times higher is the extension. But if we check the virus receptors, the TMPR SS2 and the ACE2, in the colon site, we have 20 times higher receptor abundance expression in the colon compared to the lung, and in the small intestine, the ACE2 is 40 times higher. This is why quite important to focus on the patient and pay attention to the diarrhea. If they have diarrhea, it means that the virus get in the enterocytes, there is a replication, we will have a viral load, we will have a deterioration, and parallel with this, after 2-3 days, we will have bacterial translocation and bacterial stream infection. So leaky gut and bacterial translocation is correlated clinically with the diarrhea. not only the bloodstream infection per se or the secondary respiratory infection per se or in the background, but also the clinical operation which we are doing the staff with these patients. If the patient had a tracheotomy, more gram-positive pathogen is in the background. If the patient is tracheal intubated, is more gram-negative. If we have a high FNO, high flow oxygen treatment, then we have other pathogens with gram-negative pathogens. If the patient is on ECMO, more fungal and viral infection are compared to the gram-positive, gram-negative infection in occurrence. If it is on CRRT as well, viral and the viral and the fungal infection occurrence is higher compared to the other patients. So even or clinical operation influence the occurrence and the type of the infection. So to conclude, we have an early phase of the infection at home with a viral response phase. This is a cytopathic phase. And after that, the patient is deteriorating, arrive at the emergency department. So PCT help us to rule out the bacterial infection, co-infection in this phase and to diagnose the pure viral pneumonia. However, when the patient is admitted in the hospital, we measure the PCT on daily basis because of the immune response, antiviral immune response, because of the interferon gamma, the PCT is blocked, and if the PCT remain in the lowest range below 0.2 nanogram per ml in pure viral pneumonia. However, if we have a higher PCT, that means a bad prognosis, the severity is high, and the occurrence of the bacterial infection after 4-7 days could be ventilatory associated pneumonia, so it's a respiratory one, or bloodstream infection as well. And later on, when we have this nosocomial infection, when we had in the host the hyperinflammation phase, we had this nosocomial, the PCT rule out or in the bacterial infection. So help us to give the antibiotics accurately, to diagnose the bacterial infection parallel with the viral infection accurately. And this will influence also the outcome. Every time when you measure PCT levels, you should check the PCT levels and the kinetics of the PCT by the bands. We have a bacterial band, which is the pure bacterial infection. When the PCT is high, in the highest range, above 15, 20 nanogram per ml, it's induced by TNF-alpha IL-6. There is no interferon gamma in these cases. This is the pure bacterial infection. This could be also in these days. We have the mixed band where we have TNF-alpha and the IL-6 because it's a mixed infection in the highest range, but we have also interferon gamma in the cytokine milieu, which the TNF-alpha, IL-6, the PAMs, the bacterial induction of the PCT occurs. However, we have the break by the interferon gamma. This is why in the mixed band is between 5-10 nanogram per ml. The PCT increased, but is not able to increase so high. And then we have the viral band, which is below 0.2 nanogram per ml, and the fungal band, which is below 1 nanogram per ml. In this case, it's always the interferon gamma level are are in the highest range, and the secretion is a lot. I show you a clinical case to prove you that these exist. Is the same patient. Yeah, we can see the dynamic changes of the cytokine environment. We have TNF-alpha, IL-6, interferon gamma. Why? You can see on the bottom, we can see the days from 1 to 17 days. The patient arrived in the hospital. It was admitted with fever. The CRP is 243. The PCT is 9.43. Yeah, PCT of 10. And the CRP 240. Hemoculture positive for Klebsiella and Aspergillus. Later on, because the patient received tazocin, meropen, and voriconazole, the PCT had decreased, the CRP had decreased, and the antibiotic was stopped when the PCT was 0.2065. and the CRP decreased till 7. And the patient had again hyperpyrexia, and again the hemoculture was positive, but only for Klebsiella. So here we have a mixed infection, here we have a bacterial monoinfection. Why? Because the voriconazole was given continuously, yes? And here we have only the bacterial infection. The CRP is 240, and in this case, without the interferon gamma, the PCT is in the bacterial band, and this is the mixed band. It's 21. So it is the same patient, the same bug, and even the bug was not an MDR bug, and the resistance was not changed. So this is how we use in the bands. I show you two cases, finally, about from my practice about this COVID-19 disease and the PCT, a COPD patient with hypertension with 50-75% radiological background with GGO and so on. You know better than me that what it means. But this patient had also bacterial, secondary bacterial infection with Pseudomonas and Staphylococci. When the patient arrived in the hospital, it was admitted. The PCT is the blue line, it was 0.1. After 5 days, the PC started to increase. And what we found is Pseudomonas and Staphylococci, and ceftazidime and vancomycin was given. This was not an MDR. Fortunately, was not an MDR bacteria, also the Pseudomonas and the Staphylococci. According to ID consultation, the CRP increased. Then appropriate treatment in COVID-19 disease, the PCT had to decrease, and when the PCT was around 0.2 nanogram per ml, the antibiotics were stopped. According to ID consultation, the CRP decreased, the outcome was favorable, the patient had survived. This is another case, more severe. The pulmonological background is more severe. 60-80% of the lung is influenced by the viral load with GGO, with consolidation. Always we do a surveillance of the patient when arriving in the department. So we send swabs from the throat, from the anal site, and the anal site at the admission give us vancomycin resistant enterococci. And the patient had a mixed infection. According to the PCT level and ID consultation, you can see the PCT is around 1 nanogram per ml, increasing till 3. Meropenem, colistin, vancomycin was given. These were MDR Acinetobacter and later on PDR Acinetobacter and the VRI. And of course, at the beginning, the antibiotic treatment was appropriate. Then the resistance of the bug had changed. And Zavicefta, colistin, linezolid was given. But unfortunately, this PDR Acinetobacter was infection was running, and finally we lose this patient in a resistant bacterial infection. We were not able to treat it with appropriate antibiotics, and the PCT shows us clearly that all treatment is maybe appropriate according to the culture, but clinically is inappropriate because it is a PDR Acinetobacter in the background. So again, I will give you again these two questions. So you are admitting a COVID-19 patient with severe hypoxic respiratory failure. Would you start antibiotics within 1 hour if the PCT is below 1.9 nanogram per ml? Definitely, I cannot decide no, but I remeasure the PCT on the second day. Please give your opinion. And the second question is also the same. What would be the patient prognosis, the COVID-19 patient prognosis with severe hypoxic respiratory failure if the PCT is above 1 nanogram per ml at admission? Good prognosis, poor prognosis, and remeasure the PCT later on, or you cannot decide. Please give your opinion. So to conclude, procalcitonin has utility in COVID-19 patients. We have mixed viral infection, which varies. Incidence of two viruses parallel is between 0 and 10%. We have mixed bacterial and viral infection. The rate is 1 to 4, 1 to 10. We have secondary bacterial infection in the medical departments and also mainly in the ICUs, which are common 1 to 5, 1 to 10. And usually there is a ventilatory associated pneumonia 30-40% and bloodstream infection 30-40%, rarely urinary tract infection. The elevated PCT is prognostic because leads to significant morbidity and mortality. PCT help us to shorten the time to differential diagnosis. This is a pure viral pneumonia. This is a mixed infection. PCT helps us for fewer antibiotic prescription and reduce the inappropriate antibiotic use and shorten the duration of the antibiotic use in secondary infection, in bloodstream infection, because help us to diagnose the secondary infection, help us to follow up this secondary infection, and help us to use less antibiotic days. Thank you so much for your attention.
Thank you so much, Dr. Yanis, for this valuable and informative presentations. And we have a couple of questions that came in from the audience. One of them is, do severely ill COVID-19 patients who are on ventilators need to be checked regularly for the bacterial co-infection using PCT?
Yes, in my practice, we measure the PCT and CRP every day in the ICU. Every day, and we send culture indifferent from the so in every 2 times in a week we send the cultures. If the patient has a fever deteriorating, we send again cultures, so it means 3 times, but we measure the PCT and CRP on daily basis.
Okay, great. Thank you so much. And I have another question. In your practice, will you change antibiotic treatment if the levels of PCT doesn't decline within the 24 hours?
Yes, but I ask also the help of the other colleagues. I mean, the infectologist consultation is very important. Today I had also an infectologist consultation in a patient who had deteriorating, was intubated, arrived in the ICU, and he was continuously deteriorating, and the PCT level increased indifferent from the empirical antibiotic use by us. It was meropenem and colistin, because believe that we have this MDR pseudomonas, and according to the infectologist consultation, they said that we should check the surveillance data, and we were very happy because today we arrived swab which has these vancomycin resistant enterococci, and because of that he said that we should escalate the antibiotic therapy with linezolid, and we should check tomorrow the PCT and wait for the other cultures. So
Okay.
yes, we should change the antibiotic, we should escalate or change, but we are not alone in the hospital, the ICU physician or the medical physician. We need the infectologist consultation in this COVID-19 disease. It's not so easy.
Yes, absolutely. Thank you so much. And I have also one question. It's a very good question. The cutoffs mentioned in your presentation, can this be used with any PCT assay?
Oh, we use Thermo Fisher PCT assay. I don't know the Chinese assay, never used in my life. So I don't have a personal opinion, but I guess if you use a fake PCT, you could have a fake result, and then you could have an inappropriate treatment, even you think that you do your best.
Sure, absolutely. And just to confirm, the thermo assay is the Brahms PCT assay.
Yeah, I mean Brahms, yeah.
Absolutely. Thank you so much. And I hand it to my colleague Mahmoud if you have a question for Dr. Yanis. We can't hear you. It seems that we can't hear Mahmoud.
Okay.
I have one other question. The CRP is very well known and widely used. In your opinion, which inflammatory marker is better? Is it the CRP or the PCT?
Both in COVID-19 patients, both of them are useful, because if the PCT is below 0.2, 0.1 nanogram per ml, and I am sure that I have a pure viral pneumonia, then I can follow up the viral inflammation according to the CRP levels. But I should daily reassess that this remains only a pure viral pneumonia. And of course, I can do some chest X-rays or CT scan according to the condition of the patient. If I remeasure the PCT on daily basis and the CRP start to increase, if the PCT remain in the normal range, the viral range, and the CRP is increasing, it means that I have a viral load, I have a viral re-inflammation of the patient. If the PCT is increasing and the CRP is increasing, it's sure that I have a secondary bacterial infection.
Okay, thank you so much, Dr. Yanis. Again, we really appreciate your time. Yes, go ahead, Mahmoud.
Can you hear me now?
Yes, we can hear you.
Yanis and Shaima, for the very informative presentation. We have one question about the difference between erythrocyte sedimentation rate, the ESR test, and the procalcitonin. Similar comparison to the CRP, Dr. Yanis. Can you tell us about the ESR from your experience?
Well, in my departments, the medical one and the ICU, because work in two departments, we don't use ESR. We don't use it. But what we do, we have some scientific academical work on hemostasis, and because of hemostasis because we have pro-hypercoagulation and fibrinolysis resistance in COVID-19 disease, and because of that we did some measurements, and what we observed that, and we measured PCT also in these patients, and what we observed that we have higher erythrocyte sedimentation rate, parallel is increasing with the PCT, but also the thrombocytes sedimentation rate is changing parallel with the erythrocytes sedimentation rate. If you have a bad prognosis, you have a deteriorating of the disease of the patient. But on daily basis, we measure only the PCT and the CRP. We don't measure the erythrocyte sedimentation rate in my department.
Thank you so much, Dr. Yanis. Another question, if the time allows. when you will remeasure PCT if it is below 0.1 nanogram per ml on admission for COVID patients?
I remeasure every day, every second day, because as you had seen, more than half of the patients which with moderate severe patients, moderate ill, critically ill patients will have a bacterial co-infection, more than half. Some bacterial pneumonia, some bloodstream infection, whatever, urinary tract infection. If we would like to have a good outcome, low mortality, we need to measure the PCT to know that every day you should give an answer to yourself that these today remain, these COVID-19 disease patient remain in a pure viral pneumonia condition. Yes or no? And the answer is PCT remain in the viral range. Yes. It is not there. I have a secondary bacterial infection. I should move quickly because we have a big, large damage of the lung. There is no time. If you get a bacterial infection, you will have a severe hypoxemia, and in some days you will lose your patient, indifferent from what do you do. So very quickly we should diagnose the secondary bacterial infection. You should measure every day or every second day. No choice.
Thank you so much. Thank you so much, Dr. Llanos, for your interesting presentation and comments and questions and answers. And hope that everyone benefited from it. Over to you, Shaima, for the closing. You know, we already surpassed the assigned time.
Thank you so much, everyone. And thank you again, Dr. Llanos, for this valuable information and case studies you have shared with us. Now we're going to reveal the polling answer. And with that, I end this session. And thank you so much, everyone, for joining. Have a good evening.
Thank you. Thank you so much for the opportunity.
Thank you.